So when we look at the pediatric versus the adult ECG, really the basic principles of electrocardiography are identical to adults. There are some similarities, so we're fortunate. There's the origin of sinus rhythm and P wave amplitude. And actually the P wave amplitude I thought was pretty cool. It's something that I learned. It's the same all the way through, from birth to death. So we have that going for us. Unfortunately, there are a lot of differences. And those differences include heart rate, P wave duration, amplitudes, vectors, and even something more technological like ECG sampling rate and bandwidth. So there are some significant differences. We will not go into all of these, so don't worry too much. But I'll pull out a couple of them just so you get the flavor of the differences. So we've seen a lot of the physiologic changes due to exercise. In pediatrics, they really mirror those in adults. The athletes have larger LV wall thickness and chamber dimension, and then age, sex, ethnicity, and sport type do impact cardiac remodeling. But in my 10 minutes, I've excluded some of these things just due to time. So what then are the objectives? First of all, we're going to review age-related changes in the electrocardiogram. Then we'll look at some normal pediatric T-wave patterns. And then finally, some abnormal T-wave patterns. So I'm going to ask you a question. Hopefully you can see these ECGs. Some of them have been washed out. So here you go. You've been asked by a colleague to render an opinion on this ECG. And there's simple categories: normal, abnormal, and it depends. So by the way, it depends. You didn't know that it's actually like Where's Waldo? If you write, because this is the third talk, right? So Aaron had one, Kim had one, and I have one. So whoever finds the most it depends and what slide it was will win a prize at the end of this. Just so abnormal, or sorry, normal, abnormal, or it depends. So it depends. If you're a 16-year-old, it's sinus tachycardia, right axis, and T-wave inversion V1 through V4. So it's normal. It's distinctly or sinister, as Dr. Sharma would say, because I love that phrase. However, if you're a newborn, it's completely normal. And so in the spirit of childhood sports, everybody wins, right? So if you picked normal, you won. If you picked abnormal, you won. If you picked it depends, you won. So I'll give yourself a hand. Everybody got a prize. So when you look at the pediatric ECG, it's pretty impressive what actually occurs. You go from the fetus to the newborn to the adolescent in a pretty small time frame, somewhere between 12 and 14 years. And so really, in pediatrics, age-based criteria are required. Most of us are card-carrying members of the Davignon data set. So here's a card that has age on this side and then the values running across, because I can't remember all of these values. And in terms of sinus rate, our fastest heart rates of our life are at 1 to 2 months of age, and it's all downhill from there. And so this is important because the Davignon data set is from 1979. It's mostly Caucasian kids, and it's a small group. Fortunately, the Pediatric Heart Network is coming up with new values for these, which I think will be some dramatic changes. In terms of young athletes, I can guarantee, Aaron, that I have a picture of the youngest athlete of all of these talks. When you guys say young athletes, you talk about 35. I'm a pediatrician. Those people are old. Although old's getting older as I get older. Nonetheless, what happens, there's a lot of physiologic changes, right? When you're in utero, there's a relative RV dominance. So the RV is doing a lot of work. It's actually doing about 60 to 65% of the combined cardiac output in the fetus. And not only that, the RV, blood comes back from the right atrium, right ventricle, and actually doesn't go to the lungs, it goes across the ductus arteriosus to the aorta. So the RV in utero is seeing systemic pressure, so it's doing a lot more work. And therefore, when you're born, you have this RV dominance. That RV dominance will ultimately regress over time as that ventricle then becomes the pulmonary ventricle and the pressures are less. And so that sets up a lot of the changes that happen in pediatric in the ECG in the first 1 to 4 years. So if we just looked at axis, each of these slides will be similarly set up. How does it start and then what happens? So at birth, there's RV dominance, and so the mean QRS vector is rightward because the RV is more dominant. So a normal axis at birth is 130 degrees, and at 1 month, 110 degrees as the RV decreases and the LV increases in dominance, and then ultimately by about a year of age, the axis is more akin to that what you see in adults. And so this is related to the RV dominance decreasing. And similarly, the QRS complex, right at birth, the RV is dominant. So if you look at V1, the R wave is much greater than that of V6. And then again, as the RV dominance decreases, by 4 months of age, the R in V1 is getting smaller, the R in V6 is getting larger, and then by about 4 years of age, again, you see that more typical adult pattern with small R waves in V1 and larger. And as the child grows and the ventricular mass increases, so too does the QRS duration. So again, all of these changes with which, honestly, a card is required, it's not as simple as just cutoffs, every 110 or 120. And so importantly, I was asked to focus on T waves. And so how do they start? Right after birth, the T waves are actually upright in the right-sided leads. And then by a week of age, it's actually flip. Now they're negative in the right precordial leads. And at some point, they will then resemble the adult pattern with positive T waves in the right precordial leads. And so I'm going to ask you yet another question. At what age do the T waves of pediatric patients resemble of those of the adult? Is it 8 years, 10 years, 12 years, or 16 years? So you can think about that. There's an answer coming, don't worry. So the question really is, when do T waves grow up? And when you look at studies on T wave inversion and right precordial leads in adolescent athletes, essentially as the right-sided T wave inversion decreases with pubertal development, or alternatively, they become upright as you go through puberty, such that by age 16, T wave inversion beyond V2 is quite abnormal. And this is just a graphical representation of that with percent T wave inversion, and by age 16, the majority of them have the more normal adult appearance of the T waves. Now, if we actually change this slide to when do cardiologists grow up, that x-axis would have to extend way beyond 19 for sure. And so, there's this T wave inversion in right precordial lead. So here's V1, V2, V3. And so when you're less than 16 years of age, it's called this juvenile T wave pattern, which is pretty interesting because as a pediatrician, I'm an electrophysiologist. I thought I was knowledgeable of these things. I'd never heard of this juvenile T wave thing. And I'm like, oh my God, do I have a knowledge gap? Like, what's wrong? And I realized in pediatrics, we just call it normal. We don't actually name it. And so I've actually felt relieved. But when you look at it, if you're less than 16, which is mostly prepubertal, that's a normal T wave pattern. However, if you're over 16, this typically overlaps with pathology and requires further testing. And so if you just boil it down to what are abnormal T waves in children, you have look for additional evaluation. If you have T wave inversion in the anterior leads beyond V2 in asymptomatic athletes over 16, T wave inversion in inferior or lateral leads, and then the deep T wave inversions. And so just to summarize, the interpretation of pediatric ECG is challenging because there are these age-dependent changes, heart rate, intervals, axis, and voltage. And there's a high prevalence of T-wave alterations that can normally be observed in children, which makes it tough. So if you just want the take-home points and you've ignored the last, whatever it is, 8 to 10 minutes, it boils down to, if you have T-wave inversion in right precordial leads, if you're less than 16, that's normal. That's that juvenile T-wave thing I learned about. And then if you're over 16, you require further evaluation. And I think that's all. Thank you.